Yeah, this is what happens sometimes when the electrical circuits get jumbled up. So we have arrhythmias. So we start with a little bit hiccup in our presentation. Good morning, everybody. Many years ago, approximately 25 years ago, when I just joined as a cardiology fellow in PGH Chandigarh. It was my first duty as a duty cardiologist that evening. So I was very jittery and I was very low on confidence. So I called one of my seniors and said, I can handle MI, I can handle shock, I can handle anything. But how will I handle arrhythmia? So how will I interpret an ECG? If I see an ECG and a rhythm disturbance, if I cannot understand, what do I do? Because in the middle of the night, I'm the only cardiologist available in the entire hospital. And I'm not even a cardiologist, I've just started my training. So there was this guy who was my senior who said, don't worry, whenever you look at a rhythm problem, it's either the heart rate is very slow or the heart rate is very fast. Sometimes there may be extra beats, sometimes there may be skip beats. Sometimes there may be a beat missing, sometimes there may be an extra beat, and sometimes the beats are irregular. So most of the cardiac arrhythmia spectrum involves these 4 or 5 conditions. So he said, if the heart rate is very slow, all you have to do is put a pacemaker, temporary pacemaker. If the heart rate is very fast, look at the patient. The patient is stable, you don't understand the ECG, you can call for help. If the patient is unstable, give a shock. So this is the basic rules of handling an arrhythmia in the setting of an acute intensive care unit. So basically, we should remember that we are not treating the ECG, but we are treating the patient. So this is, can anybody recognize who are these 6 different people? Is it the same person or a different person? Or is the same person in different makeup, or is it different people playing different roles? So it's the same person playing different roles. So we recognize, in spite of the fact that they are looking different. So how do we recognize? How do we recognize that the same person is the same actor playing different roles? So because we recognize by the nose, by the forehead, by the eyes, and by the facial features. So most of the activity of recognizing an arrhythmia relies on recognition of a pattern. So pattern recognition is the most important step in recognizing an arrhythmia. How do we recognize a normal sinus rhythm? So normal sinus rhythm has got certain characteristics, like an actor has a certain kind of a nose, certain kind of eyes, certain kind of a chin. So normal sinus rhythm has a certain pattern. It usually has a P wave that precedes every QRS complex, and the QRS complex is less than 120 milliseconds in width, and it is followed by a T wave, which is usually upright. And the P wave is usually regular, the P waves are regular and usually upright in leads 2, 3 and AVF, and they are inverted in AVR. So this is how a normal sinus rhythm looks. So once you are aware of what is normal, it is easy for you to identify what is abnormal. So anything that does not look like this is obviously abnormal. So what is this? The rate is very fast, so it's a tachycardia obviously. The rate is more than 100, so it's a tachycardia. But is it normal or it's abnormal? Is there a P wave preceding every QRS complex? Yes, there's a P wave preceding every QRS complex. And is there a QRS complex that is narrow? Yes, it is narrow. Is there an upright T wave following the QRS complex? Yes, there is in most of the leads. So what is this? So this is a sinus rhythm, but there isn't tachycardia, so we call it a sinus tachycardia. So this is how we try to interpret the ECG. Similarly, this is another tachycardia, but is there a P wave preceding every QRS complex? No, there is no P wave preceding every QRS complex. So obviously this is not a sinus rhythm, but this is a tachycardia. But the QRS is narrow. Therefore, the QRS is occurring because of conduction through the normal conduction system. So the rhythm is arising above the ventricles. Because it's arising above the ventricles, we call it a supraventricular tachycardia. This is another example of a supraventricular tachycardia. It is enough for us as an ICU physician or a critical care physician to identify this as a supraventricular tachycardia or a ventricular tachycardia. Because if you call an electrophysiologist at this stage, he will say, oh, this can be ventricular tachycardia. Because it's narrow QRS, it can be ventricular tachycardia. But we don't want to get into those subtleties of over specialization. So what we are concerned is that in the critical care setting unit, if it's a narrow complex tachycardia without a preceding P wave, we call it a supraventricular tachycardia. So these are all supraventricular because they are arising above the ventricle. Similarly, this is another example of another tachycardia. This tachycardia, but obviously there is no P wave preceding every QRS complex. In the presence of P waves, you see what are called fibrillatory waves. They've got irregular, different shapes of P waves which are in different directions and which are obviously irregular. So this is the typical ECG of what we call atrial fibrillation. So atrial fibrillation is obviously recognized by the presence of an irregular, a grossly irregular rhythm. The ventricular rate is usually rapid. The atrial rate is very fast, but the ventricular rate is variable. It won't be as fast as the atrial rate because many of the impulses are blocked in the region of the AV node. So instead of the normal P waves, you see fibrillatory waves of varying size, shape, and direction. And you cannot have a measurable PR interval. And the QRS is usually narrow in this situation. This is how you recognize atrial fibrillation on an ECG. So this is how you manage atrial fibrillation. I'm not going to go into the details. This is yet another rhythm which looks a little more regular than the previous rhythm. And the P waves also are looking a little bit more regular. This typically look like a sawtooth pattern. So these are looking like fibrillatory waves, but they're more regular. They seem to be of similar shape, similar size, and similar direction. So this is what we call atrial flutter. This is a more organized rhythm. In atrial fibrillation, there is no organized atrial activity. In atrial flutter, there is organized atrial activity. So this is called atrial flutter. And these are the identifying features of atrial flutter. So this is a rhythm strip of a patient who had, again, a tachycardia. So is there a P wave preceding every QRS complex? Yes. Is the P wave looking normal? More or less. Is the QRS looking normal? No. The QRS looks a little broad. So this ECG was interpreted as an atrial tachycardia with a first degree AV block because the PR interval was prolonged. In the same patient, when we did carotid sinus massage, you see what is happening. So as you see, as you go forward, is this pointer not working? Oh, there's a laser, right? Okay. So as we do the carotid sinus massage, you can see that towards the right end of the strip, you can see more and more P waves are appearing. And in the bottom strip, you can see that there are a lot more P waves. And the number of QRS complexes are decreasing. So obviously this is not a sinus or an atrial tachycardia. So there are more P waves than you can actually see on initial inspection. So this is the situation where when you see a P wave right in the middle of two QRS complexes, you have to look for a hidden P wave within the QRS complex. Now you can see that the QRS complex is slurred because there's a P wave which is superimposed in the QRS complex. This is called the Biggs principle. The Biggs principle suggests that if there's a P wave right in the middle of two QRS complexes, you should try and look for a P wave that is hidden within the QRS complex. So this is typically an atrial tachycardia or an atrial flutter with a 2-to-1 AV conduction, and you can unmask the P waves, the hidden P waves, by doing a vagomimetic maneuver such as a carotid sinus massage. So typically this is how we treat the supraventricular tachycardia. We either do a carotid sinus massage, you can give intravenous adenosine, intravenous verapamil, triltiazem, or beta blockers. And one important thing is how do you give adenosine, because this is what you frequently encounter, what you frequently need to do in the critical care setting. We need to give 6 to 24 milligrams of rapid intravenous push into a large bore peripherally central vein. And this has to be immediately followed by a 20 cc rapid flush. That is because adenosine has got an extremely short half-life. And then when you give adenosine, you do not withdraw blood because adenosine gets deactivated when it's in contact with the blood. So you need to give a rapid IV push and followed by 20cc flush. There can be chest tightness or bronchospasm. There can be transient asystole. There can be AFib precipitated. And somebody has had a coffee or tea prior to the injection, their efficacy may be reduced. But this is how IV adenosine has to be given. Now let's come to the other kind of tachycardia, which is the ventricular tachycardia. Obviously, ventricular tachycardia differs from ventricular tachycardia differs from supraventricular tachycardia by the fact that the QRS complex is broad. Because the tachycardia is arising in the ventricle, it doesn't follow the normal conduction system. Therefore, it is conducting from one cardiac muscle fiber to another cardiac muscle fiber. Therefore, the QRS duration is prolonged, and therefore the QRS is broader than 120 milliseconds. And obviously, because it's a ventricular tachycardia, the QRS complex is not preceded by a P wave. So this is how you diagnose ventricular tachycardia. Broad complex tachycardia, where the QRS complex is broader than 120 milliseconds, but the QRS is not preceded by a P wave. So this is how you diagnose ventricular tachycardia. So for the level of the critical care, anything which is like this, so the broad complex, without a definite P wave preceding the QRS complex, it is safe for you to assume that it's a ventricular tachycardia. There's another example of a tachycardia. Can anybody say what is this arrhythmia? You tell me, is it VF? So this is what we call a polymorphic ventricular tachycardia. Obviously, you can see that the first beat is a sinus beat. This is a sinus beat. This is followed by a rapid series of wide complex beats at a very fast heart rate. And this is obviously ventricular tachycardia. But what is this ventricular tachycardia? If you look at the shape of the QRS and the direction of the QRS, it is changing, it is widely varying. So this is called a polymorphic ventricular tachycardia. And because you can see the QT interval here is prolonged, in the presence of QT interval, this kind of a polymorphic ventricular tachycardia, it is called torsade de pointes. It's a French term. It's called rotation of points. So because the axis is rotating around the axis, because the direction of the QRS is changing, we call it a torsade de pointes. So this is typical of what happens in patients who have a QT prolongation because any reason, because of a congenital disease or because of a drug, because of low potassium, whatever causes a QT prolongation, this kind of an arrhythmia can occur. So when this kind of an arrhythmia occurs, what would you do? Yeah, if there's hypomagnesia, IV magnesium will help. So this is usually an incessant kind of an arrhythmia. So what we frequently do is we give a DC shock. You give a DC shock, the tachycardia comes back. So this is a hemodynamically unstable VT, and this rapidly degenerates into ventricular fibrillation. But unfortunately, you keep giving a DC shock and it keeps coming back. So you have to treat the basic cause. So you have to, most often, this kind of a VT is produced by a pause, because of a pause or a gap in the rhythm. So what you have to, most of this polymorphic VT is pause dependent. So you have to prevent the pause. So one very effective strategy that works in these patients is to do a temporary pacing and keep pacing at a rate of 100 or 90 and prevent a pause. So you'll break the cycle of this polymorphic ventricular tachycardia. So I'm going to show you a case of a young girl who was 13 who presented with history of seizures. She was brought to the ER with a history of seizures when she went down into the swimming pool. And when she came in, and she was slightly disoriented but conscious, and this is what her EKG looked like. The EKG, what does it show? It shows a long QT interval. You can see the QT interval is long. So this is what we call a long QT syndrome. Long QT syndrome is an inherited channelopathy, is an inherited disorder of cardiac rhythm, where the heart is structurally normal, but because of a malfunction of the ion channels inside the heart, inside the myocardial muscle fibers, you have which is manifested as a prolongation of the QT interval, that makes them vulnerable to cardiac arrhythmias. And what kind of cardiac arrhythmias they have? As we showed earlier, so this is another boy who had repeated neurology consults because of refractory seizures. His EEG was repeatedly normal, and yet he was continuing to have repeated episodes of seizures, and ultimately somebody had the sense to do an EKG, and EKG shows a long QT interval. And this is how, and this patient, while he was being observed in the hospital, the same boy, he threw this kind of interval. So this is what typically happens in a long QT syndrome patient. Because of the long QT, because of the increased vulnerability of the heart for polymorphic ventricular tachycardia, whenever there's an ectopic which falls at a vulnerable period in the cardiac cycle, this initiates this kind of a polymorphic ventricular tachycardia or torsades de pointes, which can lead to cardiac arrest, which can rapidly degenerate into ventricular fibrillation and cardiac arrest. So long QT syndrome is a rare but often missed diagnosis in young individuals who often keep going to a lot of specialists, especially neurologists, with history of seizures which are not undiagnosed and unconfirmed. So the three major phenotypes of long QT syndrome. The long QT1 manifests with broad T waves. The majority of the prolongation of the QT interval is because of the prolongation of the T wave interval. They come with a broad T wave like this. And then typically syncope in these patients are typically triggered by swimming. So if you come across any young individual who has history of loss of consciousness on entering a swimming pool, this is the most likely diagnosis that come to your mind. And long QT2 is characterized by the presence of notched or bifid T waves. And in these patients, typically more than exercise, emotion and startle responses like auditory stimuli, like sudden ringing of a bell, sudden sound, or a sudden doorbell ringing, these often precipitate syncope in these patients. Long QT3 is the least common of all the three, and in these patients it is because of the prolongation of the ST segment. The T wave is normal, but the ST segment is prolonged, and these patients typically have syncope during sleep. So in these patients, beta blockers are least effective. These are the several criteria. I'm not going to go into the details. So this is yet another rhythm disturbance in a patient who was in the ICU. And you can see that the first two beats are sinus beats because they are preceded narrow QRS preceded by a P wave. And the next 6 beats are broad QRS and they are not preceded by a P wave. So this is some kind of a ventricular rhythm, but you don't call it tachycardia because the rate is less than 100. And again, there's an intermittent sinus beat, again 4 abnormal beats, and again sinus. This kind of a rhythm, this kind of a pattern is very typical of what we call an accelerated idioventricular rhythm. So this is because typically occurs in the setting of an acute myocardial infarction, especially after giving reperfusion therapy, giving thrombolytic therapy, or during a primary PCI. And this is a frequent rhythm. This doesn't often require any intervention. And it's not hemodynamically disturbing, this kind of rhythm. So this is whenever the sinus rhythm accelerates, the accelerated idioventricular rhythm disappears. So this typically happens in the setting of an MI, and the treatment is often intravenous magnesium. So this is yet another case example of a patient who had a cardiac referral from an ICU because of ST wave abnormalities. And when you see this carefully, you can see the T wave. Again, it looks like a notched T wave. Similarly, here also it looks like a notched T wave. This is not a notched T wave. This is actually U wave, which is occurring close to the T wave. So this kind of a situation where the ECG shows prominent U waves and a prolonged QTU interval. It's not a QT, but it's a QTU interval is prolonged. This is very typical of hypokalemia. So quite often hypokalemia is one of the commonest causes of ECG abnormalities in the critical care unit. And then, and what is important is that before your laboratory shows hypokalemia, the ECG will show hypokalemia. But often when we say, okay, what is the potassium? We say, oh, morning potassium was normal. but the ECG now shows this. You are almost 100% sure that you are dealing with hypokalemia. And this is an example of another electrolyte abnormality where again the QT is prolonged, but it is prolonged because of the prolonged duration of the ST segment. This kind of a QT prolongation is also typical of hypocalcemia. So hypocalcemia also frequently presents with this kind of an ECG. And here is the opposite of hypokalemia is hyperkalemia. The T wave is called a tent for potassium. So as the potassium goes down, the T wave goes down, and the potassium goes up, the T wave goes up. So here is a tall upright T wave which is very typical of hyperkalemia. So again, this is also very important because this often the EKG in hyperkalemia is quite sensitive and quite specific, and quite often before you get the lab, because the lab result takes an hour or 2 hours to come back, but the ECG is there right in front of you. So these are the various stages where changes occur in hyperkalemia and hypokalemia. At serum potassium of 5.5, the T wave becomes tall and peaked. At 6.5, QRS changes start. At 7, the P waves become decrease in amplitude and ultimately become invisible. And beyond 8, there is what is called a sine wave pattern, and this precedes complete asystole or ventricular fibrillation. This is an ECG that you often see in acute neurocare units. A patient who is recovering from a subarachnoid hemorrhage shows this kind of an ECG. You don't have to panic because this is very typical of a patient with raised intracranial tension due to a bleed. They can have these deep T wave inversions. In fact, it is known that patients who have intracranial bleeds have as much incidence of arrhythmias as patients who have an acute myocardial infarction, and this is because of the sympathetic surge that occurs because of the intracranial hypertension. And what does this ECG show? There's acute inferior wall MI because there's ST elevation in lead 2, 3 and AVF, and there is reciprocal ST depression in 1 and AVL. There's another pattern of an ECG that is very subtle and often missed when the patient comes to the ER. So you can see that there is the terminal negativity of the T wave in V1, V2, V3 and V4. This is referred to as anteroseptal ischemia, but what is more important is this is called Wellens warning. So this kind of an ECG rhythm, when you see, you have to be extremely fast in acting on this patient because this often predicts that there's a proximal LAD lesion and proximal critical lesion of the left anterior descending artery, and this indicates an impending massive anteroseptal myocardial infarction. So these are the patients that need to be referred for a primary PCI as early as possible. This is an interesting ECG which shows, as all of you can see, that there is some T wave inversion AVL and some T wave inversion in V1. So this is often interpreted as some kind of an ischemia of a lateral wall ischemia or something like that, because there's some ST depression in V5 and V6. But this is a classical example of an early inferior wall infarction that may be missed on ECG. Here is the value of looking at the AVL. What you are actually looking at is the reciprocal change in the AVL. There's very subtle ST elevation, which is most easily appreciated in lead 3. But what is more important and more obvious than the ST segment elevation is the reciprocal ST depression in AVL. So sometimes we miss this and we keep waiting for the patient, and an hour later things become more obvious, the ST segment elevation becomes more obvious. So what is important is for us to be sensitive to the fact that the early signs of an infarction can be subtle and often be missed. And that's the importance of doing a repeated serial ECGs in a patient who comes to the emergency with typical chest pain. There's another case of an MI, and you can see that there is ST elevation in lead 3 and AVF. At the same time, there is significant ST depressions in V1, V2 and V3. This is a classical example of a true posterior wall myocardial infarction. Because we don't have any ECG leads on the posterior aspect of the heart, what we see in a posterior wall myocardial infarction is the mirror image or the reciprocal changes that occur in the anterior leads. So the ST depression in V1, V2, V3 are actually a mirror image of what would be ST elevation if you put leads on the posterior surface of the heart. So this is a typical example of a posterior wall myocardial infarction. There's also yet another example of inferior wall infarction, very early inferior wall infarction, especially in the presence of a left anterior hemiblock. So this is another example of a patient with an MI, and you can see that there is a significant ST elevations in V1, V2, and there is also presence of a right bundle branch block. These are the patients who are very sick, and these patients without adequate treatment have a 60 to 70% mortality. It's very important for us to recognize this kind of a pattern. This is an example of, again, an inferior wall myocardial infarction. You can see the ST elevation in lead 2, 3 AVF and reciprocal ST depression in AVL. What is important is that there is no P wave preceding a QRS complex. So this is not a normal sinus rhythm. For a normal sinus rhythm, you need a P wave. There is no P wave, so this is a junctional rhythm. There is an inferior wall myocardial infarction that is complicated by a sinus arrest and a junctional escape rhythm. So this is one of the common complications of inferior wall myocardial infarction, and these patients may require a temporary pacemaker, but often this gets corrected by giving intravenous atropine, especially if the heart rate is low. This is yet another example of an inferior wall myocardial infarction. You can see the tall tombstone-like ST elevations in lead 2, 3 and AVF. This is the inferior wall myocardial infarction. But what is very important is that the rhythm is not regular. So what is striking about the rhythm? You have 2 beats, 3 beats, 4 beats, like that. This is what is called group beating. So group beating is a very typical picture which indicates that there is a second degree AV block of the Ventricular type. So whenever there is a Ventricular type or a type 1 morbid second degree AV block, you get this kind of a group beating, which is also a complication of inferior wall MI. This is a patient of inferior wall MI, and again you can see the QRS is regular, but every QRS is preceded by P wave, but the PR interval is varying. So the QRS interval, the RR interval is constant, the PP interval is constant, but the PR interval is varying. It indicates that there is dissociation between the P waves and the QRS. So this is what happens when there is complete heart block in a patient with inferior wall myocardial infarction, because there is a complete AV block. The P waves are not conducted to the ventricles, and the ventricles are guided by a junctional escape rhythm. And this is the example of a patient who's got a massive global infarction. You can see ST elevation in practically every other lead. And finally, my last 2 slides. So this is a young man who had come to the ER with history of chest pain. On further examination, this patient also had a history of fever. So what do you see in this patient? You see ST elevations in lead 2, 3 AVF, V5 and V6. So could this be an inferior lateral myocardial infarction? Yes, this is a sign of stage 1 of pericarditis. There is diffuse ST segment elevation with concave appearance in the inferior and the left procardial and pericardial leads. And another important sign of an acute pericarditis is this. This is called a depression of the PR segment. The PR segment is normally horizontal and isoelectric, but there's a depression of PR segment is quite specific for acute pericarditis. In addition to that, we can see that there's a downsloping of the TP segment. From the transition from the T wave to the P wave, you can see that there's a downslope. This is called a downsloping. It's called a Spodek sign. This is also a very important sign of pericarditis that helps you differentiate pericarditis from acute myocardial infarction. So this patient, you should not make a diagnosis of acute MI and should not give him thrombolysis, because you'll end up with a cardiac tamponade. So it's important that you recognize signs of pericarditis, which can be a mimic of acute MI. This is a patient who was brought in the ER with acute onset of breathlessness. On examination, he had tachycardia, clear lungs, absolutely clear lungs. And what does the ECG show? It shows sinus tachycardia. It shows Q waves in lead 3. It shows an S wave in lead 1, and there's T wave inversion in lead 3. This is called an S1 Q3 T3 pattern, which again is a very useful sign of acute pulmonary embolism. So the diagnosis will be made when you do an echo. You will see that the left ventricle is normal. There is no regional wall motion abnormality. but there may be dilatation of the right ventricle or the right atrium, and the CT pulmonary angio will confirm the diagnosis. So therefore, the take-home message from this morning's talk is that we have to treat the patient and not the ECG. We have to look at the clinical picture and assess the urgency of situation. When there is not much urgency and when you have doubt, please do not hesitate to call for help. Even I still do call for help when I have a doubt. Thank you very much.